Good morning. When we speak about infertility, we begin with a fundamental truth, that the ability to build a family is a basic human right. Now that's important, so I'll state it again. The ability to build a family is a basic human right. Infertility is a disease, is defined as such by major organizations, including the American Medical Association and the World Health Organization. And it's recognized as a disability by the Americans with Disabilities Act. Like any other medical condition, patients with it deserve access to diagnosis, treatment, and emotional support. But the reality is that access to infertility care is not always equitable. The ability to reproduce affects an individual's and a couple's physical and emotional well-being, social stability, and sense of identity. In some communities, infertility carries stigma or isolation and can lead to serious psychological distress, including depression. Here in Massachusetts, we have one of the most comprehensive fertility insurance mandates for infertility coverage in the nation. Yet, significant gaps in access still exist. At Mass General Brigham, we've seen that one of the most significant barriers to infertility care isn't just cost, it's understanding how to access coverage. Patients often don't know what their benefits are, how to begin the process, or where to turn for help. That lack of information becomes a silent barrier to parenthood. We're working to change that. We're making information about infertility benefits available in multiple languages, including English, Spanish, Portuguese, Haitian Creole, and Mandarin Chinese, and collaborating with community health centers to ensure that people get accurate, culturally sensitive information about their options. Our hope is to improve access, especially among our minority and disadvantaged patients. But improving access requires more than patient education. It calls for multidisciplinary collaboration among clinicians, researchers, entrepreneurs, policymakers, and health leaders to build an infrastructure that is equitable by design. Everyone deserves the opportunity to build a family. It is our collective challenge and responsibility to make that opportunity real for every community we serve. Thank you.
All right. Hello, everyone. Thank you so much for being here. Thank you to my panelists. As we start, I just want everyone to introduce yourself and explain a bit about your involvement in this space, starting with Dr. Alan Penzias.
I'm Dr. Alan Penzias. I'm a reproductive endocrinologist at Boston IVF, having been in practice for about 30 years. I'm the regional medical director of the Northeast for EVRMA North America and a member of the EVRMA Global Research Alliance.
Excellent. Thank you so much for being here. Libby Holm.
Yes, hi, Libby Horn. For the last 5 years, I've had the privilege of leading the fertility therapeutic area at EMD Serono. We're a Boston-based biotechnology company. We're a research-driven organization that's focused on developing specialty medicines for difficult-to-treat conditions like multiple sclerosis, rare cancers, and of course, infertility treatments, which holds a very special place in our history and our legacy. We've been developing therapies for fertility treatment for over 80 years. 40 years ago, our science was instrumental in the birth of the first IVF baby, and we count our success in babies like most people in this industry. We've counted more than 6 million babies born with our medicine since then.
Excellent. Thank you so much for being here as well. And State Senator Julian Cyr.
Good morning, good afternoon, I should say. I'm Julian Cyr. I represent Cape Cod, Martha's Vineyard, and Nantucket in the Massachusetts Senate. I serve as the Assistant Majority Whip, and I've worked on healthcare policy and public health policy and LGBTQ equity through my tenure in the legislature. And I'm the lead sponsor of a bill, an act relative to LGBTQ family building, where we see some pretty significant gaps in access. I've seen that in my own personal life with friends and family, and then looking at this from a policy perspective as well.
Excellent. Well, thank you all for being here. We're going to have a great discussion today. I want to set the table first and talk about insurance, because that's often how many people kind of first come to experience their infertility coverage. Alan, you know you've done research in this area, and it was a centerpiece of my reporting as well, showing the gaps in the insurance mandate. I mean, does Massachusetts have a comprehensive mandate, or what needs to change in order to really move the ball forward?
Yeah, thank you, Jessica, for that. As Dr. Hornstein said, we have the best insurance mandate in the United States. There are about 17 states that have an insurance mandate to cover infertility. But yet, only about 1/3 of the patients who live in Massachusetts are actually covered by the mandate. Why is that gap there? It turns out that about 50% of patients work for self-insured companies, and the ERISA Act, the Employee Retirement Income Security Act, nullifies mandates. Now, there are mandates in all sorts of things, not just in fertility, but for coverage of oncology or limb replacements and a variety of things. And every one of the 50 states has insurance mandates, but all of those mandates are nullified by the ERISA Act. So that's half of the couples, or individuals or people who are trying to get pregnant. And then another 20% who are on public assistance, and then the military, the VA, et cetera. So really, even with the best insurance coverage, we only have about 1/3 of people who get that coverage.
And now, Julian, you have proposed legislation that's seeking to change the definition of infertility and also expand some coverage for Medicaid, which is a huge gap in Massachusetts' mandate, does not include anyone on Medicaid. How will that change things? Does it go far enough? Is this the first step? Like, how are you kind of envisioning this legislation in the broader picture?
So while in Massachusetts we have a broad mandate, the law is actually quite brief, and it is allowed for a series of loopholes that effectively, if you are not infertile by way of basically a 6-month period where you and your spouse, heterosexual spouse, are essentially trying to get pregnant for 6 months, you can't get pregnant, you're going to get coverage if you have commercial insurance in Massachusetts. However, if you are infertile not for a medical condition, but I don't know if I should call it social or the very fabric of the family that you're building, right? That coverage is not there. And even worse, we don't have coverage for some of the common sense procedures that help people get pregnant that may not be full sort of IVF, but there's no sort of framework for coverage there, right? So I've seen this in my own family. I've had several family members and numerous friends aim to build a family. And the length, these are all queer folks. These are mostly women in couples. And they continue just to run into these barriers, right? Where it's incredibly costly, right? $10,000 or more if you are going to go within the medical system. And then I know several, including a couple very close to me, who opted actually to go outside of that system, right? The old-fashioned turkey baster method, right? And that's because you just can't really get coverage within the medical system. And so what this bill is aiming to do is, yes, get a little more specific about the definition of what we consider infertility and to close some of those loopholes, but then also say, look, we've got to have some cultural competency here, and we have to understand how people are building families in 2025. Massachusetts has actually, I think, among the highest rates, if not the highest rate, of families that are created in non-conventional means, right? We should be responsive to that. You know, if you look at data, go look at health data, right, about where younger people are identifying, right? 1 in 5, young folks are identifying as LGBTQ in some way. We need to be responsive to their needs as these folks become adults and as they seek to build families. And right now, it really becomes an affordability piece. And honestly, if you got the resources to do it, you pay. And if not, it's a really, really tough, costly choice that some aspirational families just can't make.
Yeah, we're literally picking and choosing who gets to have families here. Libby, from a manufacturer perspective, a drug manufacturer perspective, with a national footprint, international footprint, when it comes to drug coverage, I mean, because infertility treatment is often this like two-prong thing, you know, there's the clinic costs and then there's the drug costs. Do employers and insurers nationally go far enough with their coverage for drugs? Or from your vantage point, have you seen gaps in what is covered and what your patients are kind of experiencing?
Yeah, so I think there's certainly gaps in the U.S. when you look at from a data perspective. So we have a couple of imperfect sources of information for this. One is the Mercer report, and the most recent study in 2024 said that 47% of large group employers are currently covering fertility benefits. So that number has been improving. It's about double what it was a decade before, but it still leaves 50% of employees out of the equation. And then on top of that, maybe building on some of the comments from Dr. Penzias and Julian, the quality of those benefits can range massively. So even a patient who has fertility benefits from their employer may wind up maxing those benefits out or reaching the end of their coverage before they take a baby home. And so they'll wind up, even those patients paying fully out of pocket for fertility services in order to build their families.
Yeah, so clear gaps do exist, and I want to talk about one of the biggest impediments given those kind of gaps, which is the cost. Julian, how have you seen costs be an impediment or a concern to getting infertility care? You mentioned family members who've gone outside of the system. How else have you seen kind of costs materialize from a patient perspective?
From a patient, certainly from a macro perspective, right? Costs drive so much of our conversation in healthcare. On the more personal level, right? It's just really informed the choices and options that people can make. And often these procedures, right? I think of several instances, particularly my family members, who were basically being like, right, like first of all, it starts, how do you do this, right? And even finding a place that can inform you to do this. Shout out to Fenway Health, which is just around the corner, which does have sort of a good briefing introductory program you can go through to see what the options are. But say you're someone who maybe would like you're not necessarily infertile, right? You just don't have a partner who you can, conceive with, right? If you're looking for assistance, say in becoming pregnant with a known donor, you can't do that through the medical system. If you're looking for assistance in being inseminated with frozen sperm, right, that you've purchased, again, you have to pay for that sperm, and you can't really get coverage for the help there. And these are actually, from a cost perspective, a heck of a lot less expensive than requiring someone to go through a 6-month process to prove their inherent infertility, at least in the context of that couple, waiting to get the insurance coverage and then finally getting coverage for actually, in many cases, a procedure that is just much more significant than what you actually need. So these are really, these have really, I've seen these conversations and discussions play out with my friends, with my family members. I'm also someone who, on the other side of this, there's the storage conversation, and there's actually the also the sperm donation conversation here. As someone who's a sperm donor, as a known donor, to friends of mine, that whole process as well. There's no coverage for that whatsoever, and the process to go through is just deeply lacking in cultural competency. As someone who's gone through this. Rather curious process. So we've got a lot of, what the bill is sort of aiming to do here, yes, updating our infertility laws, but also allowing for coverage of what are actually far less costly procedures that would help non-traditional families, that would help LGBTQ families, that would help single parents who are trying to build a family, who are trying to create a baby, enable them to do that. Really meeting the spirit, I think, of what was intended in this very, broad statute that was passed a number of years ago around fertility coverage.
Yeah, and Alan, what is it about the clinic that makes this process so expensive from that perspective? Why is it so, thousands of dollars for people out of pocket if they don't have insurance?
Yeah, no, it's a good question. I think that part of it is because of the regulations that we have to follow. It's a very heavily regulated by the FDA and oversight, because we want to make sure that when people go through this process that they are getting a very high quality service. And as a result, the FDA has many requirements, the College of American Pathology, the American Association of Tissue Banks, and really a lot of that is designed to ensure the health and safety of those going through it. It's certainly for the most high-tech procedures and for people who are not intimate partners with one another to prevent the disease transmission. So that, I think, adds a layer to it. It adds a little bit of complexity to the whole process, but certainly it makes it a barrier.
And Libby, there was a huge announcement by the Trump administration that suggested it would change the game when it comes to drug availability for IVF medications. Is that a Band-Aid that will, relate to one drug for one company, or do you see this as envisioning like lasting change when it comes to the cost of drugs for IVF specifically?
Yeah, I think in the short term, this is a game-changing moment for patients who are paying fully out of pocket for their prescription medicines. We'll be able to drastically reduce the price of our medications, and we would expect other manufacturers to be able to follow the same roadmap in terms of making their medications more accessible in a direct-to-consumer platform. And then we're also very encouraged by, I think that has been one of the major issues in terms of drug pricing in this category, is the vast majority of the price is not actually controlled by the manufacturer. It's controlled by a unique system in the U.S. of middlemen that also drive price. And so this new pathway allows us to come together with other those exact stakeholders and build a better solution for pricing for patients. And then you mentioned innovation. I think that's another big piece of this. This is unfortunately a category of therapeutics that has been quite stagnant in terms of innovation. And so I think the FDA is definitely showing, placing priority on this as a national health crisis has, I think, alerted the FDA and has them thinking very differently about how to create more competition, which will naturally bring down pricing as well.
Libby, sticking with you, I'm curious if the direct-to-consumer model is kind of the direction this has to go because of the price of these drugs, or do we also need more transparency within, from pharmacies, from PBMs? I talked to some patients who shopped. They called all these different pharmacies to get all the different prices. They wouldn't get the price until they had sent the prescription. Shopping for these drugs is really challenging. So, is direct-to-consumer the answer to that, or do we also need some kind of transparency here?
I think it's both, yeah, and I actually think direct-to-consumer price listings is going to help with transparency, and I hope should help patients be able to navigate what is a very complicated financial journey, but definitely believe there is more support needed there and more innovation. We talked about just the differences in benefit design. We talked to patients about their financial journey in this space, and it is a roller coaster. It's a web that you can get lost and it's extremely complicated, and you can wind up paying more for your medications than you should, just because you've landed in the wrong place or have had the wrong information. You can also get to the very finish line of deciding to enter treatment and realize that you haven't calculated for drug costs. That happens too. So there's a lot that needs to be fixed in the patient financial journey in this space as well. But I think this is a really important step in the right direction.
And Alan, apart from cost issues, getting to the clinic has sometimes been raised as a barrier. I know you've done some research in this area too. In Massachusetts specifically, most of these clinics are located in geographies that are weller off. They're higher income areas. Has that been a barrier to access for people, or how is that shaping out in Massachusetts?
One of the great things is sort of as a consequence of the pandemic is the use of telehealth. And that has been a game changer, because you're correct to be able to travel in the middle of the day to an appointment at a doctor's office, whether they're downtown, where we have some offices that are right next to the public transportation, or whether in a suburb. It just takes time. So typically, as patients who've had access and flexibility in their schedule, usually they're higher income people who have much more flexibility, but there are many workers who really don't have that time. They get a 15-minute break. And so for them to be able to go into a quiet space, use telehealth, have the same level of competent and caring healthcare delivery, get everything they need, and do it in that time slot that they can get to, has been a real benefit for access to care. It's interesting because people think, this is just doctors don't want to have come into the office and see patients, but in fact, for those who can't travel because their jobs won't let them, it's been absolutely life-changing for them.
And Julian, as you mentioned, being a sperm donor, I was wondering, was that accessible to you, or was it challenging to navigate, from the patient perspective? What did access look like from that?
Sure. On the geographic piece, right, as someone who represents islands and lives far out at the end of a peninsula, geographic access is a huge challenge for us. Telehealth, I think, has helped, but really where you look at the concentration of these services, the hinterlands in Massachusetts and rural New England, I think, are being, even still left out. Look, I have some funny stories, certainly.
Please share.
From going to the California Cryobank between Porter and Harvard Square. I think what was sort of stunning to me was just that it almost felt like I was the first gay man who had walked through the door to be a known sperm donor. And I know that's not the case because I have, I can think of a dozen people who've done that. And actually, I think of a friend of mine who's in an older generation who literally, when she went about doing this, they just walked in with, the known donor and feigned that they were a couple, right? To using using a cryobank to sort of do so. But that was really sort of, and that was 30 years ago, and I almost sort of wish we did this sort of same thing. The fact that the cryobank, and look, they were lovely people. I don't mean to speak ill of the providers there. And of course there's an element that's quite humiliating with a handicapped restroom and those sort of things. But they really couldn't navigate the fact that I'm on PrEP, or I take PrEP, for HIV prevention, which you talk to a queer man that has health insurance in the Commonwealth of Massachusetts and across this country, they're probably on PrEP, right? PrEP actually reduces your risk. I mean, it almost eliminates any risk of HIV transmission. It was like they couldn't get their head around it. And my friend still received a letter from the cryobank saying, hey, your known donor is high risk for HIV. You can proceed with this on your own risk, right? I mean, it's just so dated, right? And I think that is where part of this bill is trying to get at as well. It's not just the mandates or what's covered. And we've made some good progress actually working with insurers, with payers in Massachusetts to try to figure out some more LGBTQ affirming options here. But there's a cultural competency piece of this. I think back to my family members who, showed up at the hospital and again sort of felt like they were the first queer family giving birth in this hospital. I know that's not true, right? But I think we need to have training for providers across the fertility and reproductive and birthing space. And that's something I think we're going to need to do, and particularly as we're responsive that we're seeing more and more of these families, more and more of these patients walking through the doors of providers. They should have some competency there.
There's some audience questions that have come in, from a national perspective, and Alan or Julian, I think you might be the best to answer these. One person asked about state-level mandates for fertility coverage, how they vary in inclusion or exclusion of same-sex couples, and also parental rights laws if they create additional hurdles for, this says lesbian couples, but presumably any homosexual couple building families through IVF. So I don't know if either of you have a sense of where Massachusetts is nationally when it comes to inclusion of LGBTQ families or family laws and how those kind of get in the way.
I think it really speaks to what the definition of infertility is. And the American Society for Reproductive Medicine made a huge step forward in October of 2023 when they changed the definition from the traditional definition that Julian was talking about to basically telling people that it's the ability to have a child when you want, with whom you want. And it doesn't discriminate against people who are same-sex couples, single parents, and I think that that's a big step forward. Right now, the law is very non-specific, but codifying that into the law, I think, is going to be a huge step forward.
Yeah, this is exactly why we have the bill, right? Which actually was advanced favorably from the Joint Committee on Financial Services, is now before healthcare financing. So that's exactly why we have this law, because to the question, LGBTQ families broadly are left behind, are not covered.
We have a couple of minutes left, and so I wanted to ask you, I always like to end these things, to like manifest a bit. There's a lot of hurdles here, there's a lot of gaps. And if each of you could change one thing to make this process better, to make access better, to make it more equitable or more affordable, what would that be? Alan, we can start with you.
I think that we need universal, equitable insurance that will cover fertility so that it will allow anybody who wants to have a baby, LGBTQ families, military, federal employees, same-sex parents, and really anybody who wants to have a child and give them access to care. And we have the science to be able to help build families. Now we need the policies to match.
Excellent. Libby?
Yeah, I'll pile on to that one and get even more tactical and say I'd like to see us update the ERISA definitions and Affordable Care Act definitions to mandate that exact definition. So we have categories for maternal and newborn care. We have categories for prescription drug medicines that are declared essential health benefits, and right now they don't speak of fertility treatment at all, and they could. And that would be a very simple, maybe not simple, but that would be a practical way to implement what was just described.
Julian, how about you? I mean, one thing I know is it's limited, but one thing if you could change.
Pass my bill. Right, this really is about updating the definition of infertility in Massachusetts so that the spirit of this law is actually inclusive of who lives in our Commonwealth and the values of our Commonwealth. And we're aiming to do that, and it's why we filed legislation. It's why it's gotten some real traction. And I think that we need some specificity here. We need to close these loopholes, and we just need to do some troubleshooting within the whole spectrum of care to make sure that we're meeting people where they are. I actually am not convinced this is a serious, major new cost on our healthcare sector, especially when we're talking about LGBTQ folks. So, hence why we filed the bill. Hence why we're trying to make the case for it, and. We think if we would pass it, it would do a whole lot of good, particularly in this environment. We talked about what the Trump administration is doing around, for IVF access or fertility or drugs. This has nothing to do about affirming LGBTQ people. This is, the most openly hateful administration we've seen on the national level targeting LGBTQ people, right? And so even more reason why Massachusetts needs to double down in protecting our residents and defending our values here and making sure that people are, as the introductory speaker said, right, that fertility is a right, and that we're gonna meet the spirit of that.
Excellent. I mean, I recognize too that this conversation comes at a perilous moment in our healthcare nationally. There's a lot of change, a lot of cuts that are coming, and so. We'll see what we can do in the next couple of years ahead, but appreciate all of you being here, sharing your thoughts, and all of you in the audience for attending. So thank you so much to all of our speakers.
So thank you for listening. I'd like to thank our panel, our moderator, our panelists. I think what you've heard is a very wide-ranging and very intelligent discussion of some of the challenges and issues that we face from a clinical perspective, a pharmaceutical perspective, and certainly a legislative perspective. I think the path forward is variable but is clear. Access to infertility care is critical to the well-being of our society. The challenges remain, and those of us who are committed need to move forward with this agenda. Thank you.